Good afternoon, Facebook family. How are you all doing today? Welcome to another Sunday chat with Dr. Madeline. We'll get started in just a couple of minutes, okay? I'm excited today. We're going to be talking about treatment options for uterine fibroids. So this is a topic that's dear to my heart. It's a conversation that I have with many of my patients, and so I welcome all of you to join. Write something in the chat for me if you're here. Just write your name in the chat and I will make sure I give you an individual shout out. Hey Number, thanks for joining. Thank you so much. Great. Last week I know we had some technological difficulties with the chat, so I'm excited that so far so good today. I can see your comments. Lee, Number, are you able to hear me okay? Okay, cool. All right. Good. I'm glad you can hear me. Awesome. Whoever else joins, please be sure to wave or type a hello in the chat, and we're going to get started in just another few seconds. Today we're going to be talking about treatment options for uterine fibroids. So I'm excited about this topic. It's a topic that is a frequent topic of conversation between my patients and I, and hopefully we'll be able to have a good discussion. And if you guys have any questions, please just let me know. I see someone else has joined. As you join, please feel free to wave or say hello in the chat box, okay? Thank you for joining. Thank you. Hi, Sandra. How are you? Thank you for joining. Sandra is a nurse up in the New York area, in the Buffalo area, and she's recently written a book that I'm looking forward to reading. It talks about how to navigate white privilege in the workplace. So, Chandra, thank you so much for joining today. It's great to have you. We're going to be talking about treatment options for uterine fibroids today. So, again, as you join in, please just wave hello or type your name into the chat box, and we're going to get started right now, okay? Again, thank you to everyone who has joined. Be sure to say hello or like and share as you're here and as you're listening. And if you have questions as I'm talking, please feel free to just type your questions in the chat, and I promise either during this conversation we're having today or afterwards, I'll be sure to make sure I give you a response to your question. So thanks again for joining. I see we have a few more people who have joined, so we'll go ahead and get started. As you join again, please type your name in the chat box or say hello so I know you're here, and I'd love to thank you personally when you join us. So today we're going to be talking about a few treatment options for uterine fibroids. So what are uterine fibroids? Many of you may be familiar with them. They are actually smooth muscle growths that happen on the uterus of a woman. They are extremely common. It's estimated that fibroids affect about 171 million women worldwide. That's a whole lot of sisters with fibroids. And here in the U.S. alone, about 26 million women are affected. So it's really something that's very common, and that's one reason why I wanted to talk about it today, because it's a conversation that comes up a lot with patients. Patients often have questions, even friends have questions about what fibroids are, what are some different ways to approach treating them, and so we're going to touch base on a couple of those things today. So again, they are benign growths of the uterus. Most times fibroids are benign. Now there's a small percentage of women who, when they do, if they happen to have surgery for their fibroids, and we send them to the doctor who looks under a microscope to see if it's only benign tissue or if there's anything else. When they look at those studies, of 100,000 women who have their uterus removed for fibroids, about 3 to 7 out of 100,000 of those women will have sarcoma, which means that fibroid has become cancerous. So you see, it's a very, very rare situation, between 3 and 7, or less than 10 women per 100,000 women. So it's not something that we see very commonly in GYN. And most times when we're following women who have fibroids, we follow them knowing that more than 99% of the time it's a benign tumor or growth on the uterus. And so, so we've talked about how prevalent it is, about 26 million women in this country. And when we look at some of the breakdown, the racial ethnic breakdown, there are some differences that have been noticed. So when you look at who has fibroids, it's something that presents about 70% of the time in white women and about 80% of the time in black women. And so we're not sure why there's that racial ethnic disparity. But we've noticed that over decades of examining what goes on or who presents with fibroids among women who present with symptoms in this country. Now, I say with symptoms because there's a difference. There are also women who never have symptoms of fibroids. Let me use myself as an example. So when I was pregnant with my third son, and they were doing an ultrasound, which we always do in obstetrics, they found a small fibroid, maybe like 1 centimeter, in the back part of my uterus. Now, it had never bothered me. I would have never known it was there if the ultrasound had not been done. But, the ultrasound saw it after I gave birth to my third son. Follow-up care, it was not seen. Maybe it shrunk back down. But that just gives you some idea of how frequently we might see something incidentally. Incidentally means the woman does not have any symptoms, she doesn't have any concerns, or hasn't presented anything that might show that she has fibroids, but if she just happens to have an ultrasound done or a CAT scan done or something like that, a fibroid might be noticed. And that's okay. It's a good thing if a fibroid is not causing a woman any problems. What we're going to be talking about today in terms of treatment options are those women for whom fibroids have become a problem. And fibroids can have a range of symptoms that are involved with them. They can cause, if they get to a certain size, they can cause a lot of pelvic pain or lower abdominal pain. They can cause heavy bleeding. They can, if they're pressing against the bladder, which is also right in the same part of the body near the uterus, they can cause a woman to go to the bathroom more frequently. If they're pressing against the rectum, they can also cause changes in her bowel habits. And depending on where they are, if they're low enough near the top of her vagina, they can also cause pain when she's having sex. And so fibroids can, do a wide range of things when they reach a certain size if they begin to bother certain women. So the other thing to know about fibroids is that we have different ways that we can treat them, but for about 22% of black women and 7% of white women, fibroids are the leading reason for women having hysterectomies. Okay, so, especially for black women, 22% of black women having hysterectomies due to fibroids, that's a significant number. Now, we're in an exciting time, actually, because, I mentioned to you that we don't really understand what causes some of the racial ethnic disparities that we see. But one of the things that has happened, actually this happened just last month, is that 2 congresswomen introduced a bill in the U.S. Senate that is proposing to study and educate more regarding uterine fibroids. Those 2 senators were Vice Presidential-elect candidate Kamala Harris, and also a sister out of New York. I think Yvette Clarke is her name. And so they talk about how commonly fibroids are diagnosed in women, especially in black women. And so this bill is proposed to, hopefully, if it's approved, if it's made into law, it'll give more funding and resources for education and for treatment and research to NIH, CDC, and HRSA, Health Resources and Services Administration. And so that's an exciting thing. So we'll see what happens. Keep an eye out for that bill, the fibroid bill, in case it does get signed into law. And, we'll be able to try to learn more about fibroids among women. So, I'm very visual, as you guys know. So as I talk about the 3 treatment options for fibroids today, I have a little schematic that I brought along for this discussion. because there are many different types of fibroids. And so here, I want you to see that this is the uterus, okay? This is the uterus. And when you see these kind of white masses here, those are examples of types of fibroids, okay? So this one here, when it's near the lining of your uterus, that's called a submucosal fibroid. That's the one that's most commonly going to cause you to have heavy bleeding. If your symptom from fibroids is heavy bleeding, it's most likely because you have one here in the submucosal area, or like this one here as well. Okay? Subserosal fibroid is this one here. Because it's outside of the lining of the uterus, that one may be more associated with pain and less associated with heavy bleeding. And this one here is just within the wall of the uterus. It varies in terms of the symptoms it can cause. And this one up here is called a pedunculated fibroid. And that's just a fancy word that means the fibroid is on a stalk. And when a fibroid is on a stalk, if the woman opts to have surgical removal, it's really easy because then you can just kind of tie off that stalk and remove the fibroid and not have to do any direct damage to the organ of the uterus itself. So those are some examples of what fibroids might look like. So I want to talk with you. The first treatment option we're going to talk about today is uterine fibroid embolization, or UFE is commonly called. And UFE is for that woman, that patient who has some fibroids, might have some mild symptoms, maybe not too bad, or maybe she just notices that it's there and she would like to try an intervention that could reduce it in size. A uterine fibroid embolization is sometimes what's discussed with a patient who doesn't really have too many concerns about her fibroids, because what it does is, oh, thank you, I see some other people have joined. Hey, Elise, thanks for joining. Great to see you. Hey, Jackie, thanks for joining. Hey, Dr. Banga, thank you. I'm so glad that you guys are here. Thanks again for joining. So, so with uterine fibroid embolization, there's a little schematic of a woman that's here on the lower side. And so I included this because I wanted to show you that this procedure is actually done. We work in conjunction with a radiologist. And what they do is, after we've done some appropriate screening tests and we determine that a woman is a good candidate for it, radiology will see the woman and they'll go through a big vessel here in her thigh. And what they'll do is inject a solution that's kind of sandy-like, kind of grainy-like, and that solution will basically block the arterial flow to the uterus. And what that does is cause the fibroid, when it's not getting blood flow, which is how it eats, that's its food supply, the blood flow. When you block off that blood flow, the fibroid will shrink and get much smaller. And ideally, depending on, you know, every woman is different in this situation, but ideally by it shrinking, the woman has fewer symptoms related to that fibroid. And so, so that's a very popular approach for women who are adamant about not wanting surgery, or you know, may or may not be done with childbearing. It can take a few years, but some women do get pregnant after fibroid embolization. And so that's always a good one to consider, again, for women who are not interested in surgery. I do have a question here from Lee Thompson. She says, are there treatments for calcified fibroids? Well, you know, Lee, it depends. If the fibroids are bothered, a lot of fibroid treatment is based on how the patient is feeling. And so if those calcified fibroids are not bothering that patient, if they're not causing pain, if they have calcified to the point that they're just kind of hanging out and they don't bother anyone, a woman can actually just continue on through her normal reproductive life pattern and not have to bother with them. However, if they're calcified and they're causing pain, a lot of times, sometimes calcified fibroids cause a lot of pain, particularly for women who are pregnant. A lot of times, you know, the baby is in there trying to stretch and get their space, and someone who has a calcified fibroid might feel very uncomfortable during that process. And so what we tend to do, you know, we try to manage it with pain medication if we can, especially if she's pregnant. We don't want to do surgery. But if a woman is not pregnant, if she has no interest in getting pregnant, then it's a matter of if that patient wants to do something more, I guess, invasive. It can be fibroid embolization, it can be a myomectomy, or it can be a hysterectomy. And we're going to talk about those in just a couple of minutes, okay? Hey, Kelly, thanks so much for joining. It's so good to see all of you today as we talk about fibroids. So I said we would talk about 3 treatment options, and uterine fibroid embolization is one of the options that I wanted to let you guys know about. It's considered it's considered non-invasive. We work alongside your GYN and radiologist work together to determine if it's a good approach for you. And it can be done as an outpatient. That's another good thing that appeals to patients. It can be done as an outpatient. Usually the recovery time is faster. If a woman has it done on a Friday, she might be back at work by Monday. And so, it's one that we like to discuss with patients. Now, again, certain procedures are not the right thing for everyone. Whenever we're talking about treatment for fibroids, we're looking at a bunch of factors. So, what's her pain like? What's her quality of life like? That's a big one. If you have if I have a patient who comes in and and thank goodness, I love it when women feel comfortable being as honest as possible. I have some women that come in and say, look, doc, I can't even wear white because I just don't know when a heavy blood flow is going to come. I have to carry a change of clothes with me because, this fibroid has gotten so bad, it's causing such heavy bleeding. I'm just not sure, how much longer I can take this. And that's absolutely important for someone to share with their provider if that's going on, because one of the big things that can impact how we approach fibroids and treating fibroids is the woman's quality of life. So always absolutely feel completely comfortable sharing with your provider what's going on in your world. If you're bleeding so heavy or you have a certain amount of pain that prevents you from, living your best life or having the sex you want to have, or even wearing the fly outfit that you want to wear, those are all things to share with your provider so that y'all can work on a treatment plan together. Okay, so the second type of treatment I want to talk about is a myomectomy. So a myomectomy is the next step up in terms of how invasive it is. The goal of a myomectomy is to remove the fibroid but leave the uterus in place. Okay, so that's the goal of a myomectomy. When we do a myomectomy, this is usually the woman who doesn't want to lose her uterus and there are a variety of reasons for that. She might still be interested in having children in the future. She might just want to keep her uterus there. There are some patients I have, and this is something you may have heard, when families talk, especially women in families, aunties, moms, grandmoms, sometimes the concern that you have is, if I get my uterus out, it's going to change up my sex life. My man is not going to be happy, my partner is not going to be happy, and it's just going to change things for me. And so that's a very real conversation to have with some people in terms of what can they expect after any type of intervention for fibroids. And for many people, having fibroids removed or even having the uterus removed doesn't affect their sex life at all. But for other people, you have to have a real conversation. If they say they feel different, what are some different things you can try to help them get to where they want to be? Hey Pam, thanks so much for joining. So Pam says fibroids run in families. Are there any links to diet or specific preventative measures one can implement? That's a great question, Pamela. So from the data that we do have, it does appear that fibroids run in families. There are some studies that show it can be linked to certain dietary things, certain types of red meat. There are people who try to change their diet and decrease meat products, and sometimes some of my clients have great success with that. So it really varies, but there are other people that try to implement these types of holistic approaches, whether it's changing their diet or trying different things, and it might be that the fibroid is of a size or in a location that that type of approach may not be as effective. So again, fibroids are so individualistic in terms of how they affect different women and the treatment plan that has to be discussed with the provider. So, but yes, those are great questions, and definitely if a woman wants to try that, one thing I'm not talking about today is some or some medical or holistic approaches to how you can treat fibroids. But absolutely, especially if a woman doesn't want to have surgery changing diets and doing those types of things are things that can definitely be tried to see if they help the fibroids. Okay, so we talked about the first thing. We talked about uterine fibroid embolization. We talked about the second thing, which is myomectomy, and how the goal of that is to remove the fibroids and not remove the uterus. One thing I will say about myomectomy, when a woman has it done, let's say she wants to have children after having a myomectomy, whenever there's a myomectomy or a surgery on the uterus, it's very, very important for women to understand if they get pregnant after that, that they have to have a C-section likely. Because anytime that there's a cut, a surgical incision into the uterus, it decreases the how effective the uterus is in staying whole when a woman goes into labor. And when that uterus starts contracting in labor, it's possible that the uterus can tear open, and that's always an emergency for both the baby and the mom. So just something to keep in mind in terms of myomectomy or any type of surgery on the uterus. So what's the third intervention I wanted to talk with you about? This is the one that's the last resort, the hysterectomy. It's, again, as I mentioned earlier, fibroids are the leading cause of hysterectomy for a lot of women in this country. For 22% of black women, for about 7% of white women. So hysterectomies, which basically means removing the entire uterus, okay? I'm not talking about the fallopian tubes. You can have a hysterectomy and leave the fallopian tubes and ovaries, but the question is, with a hysterectomy, you're removing the uterus itself, okay? And hysterectomies are basically the last approach because, again, a lot of times women don't want something so invasive. So for whom is a hysterectomy something that we consider more strongly? So if I have a patient who has a lot of pain, she's tried everything else and the pain is too severe, the bleeding is too heavy. Let's say she might be bleeding so heavily that she's severely anemic and she comes to the ER almost passed out and has to have a blood transfusion. That's a patient that I'm going to have a more serious conversation about in terms of, especially if it's happened multiple times. Hey, sis, what's going on? Let's talk about your options again, and you let me know whether or not a hysterectomy is one of the options you want to consider. It may not be. She might say, you know what, I'm just not there yet, doc. I still want to try something else. Can we try a myomectomy? So just, again, it depends, and it's very individual for each person. But again, hysterectomies are the last option we consider for someone who either has big fibroids that are disrupting their lifestyle, their quality of life, with either a lot of pain or heavy bleeding, or or other reasons. Another reason to more strongly consider hysterectomy for a woman is if her fibroids grow very rapidly all of a sudden. So let's say a lot of times you'll hear us describe fibroids using fruit or vegetables. So if a woman comes, if I'm seeing a patient in 1 year, let's say her fibroid is about this size, maybe the size of an orange. And let's say 6 months to a year later, she comes in just for her annual GYN. Maybe she notices that her abdomen is protruding a little bit more, and we do an exam, and I do an ultrasound, and suddenly the fibroid has gone from this size to maybe basketball size. Now that's a patient in whom I'd say, you know what, that's kind of a rapid growth. I would probably be more concerned about something going on with that fibroid. Now, if you recall when I started, I said most fibroids are benign. Only of 100,000, only 3 to 7 are shown to be cancerous or have sarcoma. But it's usually those fibroids that grow rapidly over a short amount of time. Those are the women for whom we consider something that's non-benign or cancerous more seriously. And for those patients, we would probably have a more serious discussion about hysterectomy to go in and just kind of see what's going on. Okay, thank you, Michelle, for joining. Michelle has a question. She says, if you have a hysterectomy, could you be exempt from certain cancers like uterine cancer? Yes, Michelle. When you remove the uterus at the time of the hysterectomy, you remove the possibility of uterine cancer. If you leave the fallopian tubes and the ovaries, there's still a possibility that a woman could develop ovarian cancer or even like a peritoneal type cancer, even without her uterus being there. So yes, that is correct. The other thing is when you remove the uterus, and the mouth of the uterus is the cervix. The bottom of the uterus is the cervix. You remove the possibility of cervical cancer as well when you remove the cervix with the uterus. There's a type of hysterectomy called a supracervical hysterectomy where the cervix is left in place. We do that occasionally for some women for a variety of reasons, particularly if we can't get the entire cervix and uterus out at the same time. So thank you for that question. And Chandra has a question. She says, why do they impede women from conceiving? Great question, Chandra. So it actually depends on the location of them. So if I have a patient who has a fibroid, let's say the fibroid is like right here in the bottom of the cervix. So when a man and a woman have sex, for there to be a pregnancy, the sperm has to come up through here, it has to go through the cervix, and it has to meet up with the egg that comes out of the ovary and down the fallopian tube to get to the uterus, okay? And it meets that sperm in the uterus, and that's how pregnancy develops. So depending on where the fibroid is located, if it's blocking the cervix, maybe the sperm doesn't get through. If it's further up into the uterus, but it's kind of blocking the cavity, it can cause difficulty that way. So it really is absolutely dependent on where that fibroid is located. So so thank you for that question, Sandra. You can also have a fibroid that's kind of blocking where the fallopian tubes are, because if that egg has to come from the ovary down the fallopian tube, when it gets to the base of that fallopian tube and it's trying to get into the uterus, if there's a fibroid there, that could also impede someone from conceiving. Hi, Michelle Lynn. Thank you so much for joining. And there's a question about, is uterine cancer hereditary? Well, in a small number of cases, it can be. One of the things, you know, when we're doing our history and physical with our patients, we always get a good family history, because one of the things we know from many types of cancers is that if there's a family history, we have to consider certain things more closely and work up women sometimes in a different way to explore things and see what might be going on. So, so yes, in some cases it's possible. We always try to ask all the questions to try to make sure we have the most comprehensive understanding of family history possible when it comes to certain types of gynecologic cancers like uterine cancer, cervical cancer, ovarian more so. Ovarian and breast cancer are more directly tied to hereditary syndromes than uterine cancer. So thank you for the question. Thank you, guys. I appreciate all of the questions today. I always promise you guys to try to keep it to about 15 to 20 minutes, and so I'm probably just a little over 20 minutes right now. And so I'm really excited that you guys joined today. I just realized I was so excited I jumped right in and I didn't give you my intro. And so if you have other questions that you think about, go ahead and feel free to type them afterwards, and I'll be sure to respond. If not later today, definitely during the week. So I'm going to give you my introduction now as we're closing down. Thank you again for joining. I'm Dr. Madeline, your board-certified OBGYN, international speaker, and published author. I work with busy women to help make sure they have specialized gynecologic care and access to birth control based on what works for their busy schedules. I do this to help women have as much freedom as they can access to help carry on their busy lives. And so I thank you so much for joining me today. And next week we'll talk some more. If you have suggestions for topics that you want to hear about, please feel free to post it in the group or include it in the chat here, and I'll be sure to get to those topics one at a time. I appreciate all of y'all. Thank you so much for joining. I appreciate you too. Thanks, Pam. Thanks, Chandra. Thanks, Michelle. I appreciate all of y'all as well. Thanks, Lee. Thanks, Jackie. Thanks, everyone, for joining, okay? Love y'all. See you next week. Dr. Madeline is out.